To open the next session, please welcome Dr. Juanita Lu-Lim, Head of the Section of Medical Oncology at Metropolitan Medical Center Manila and past President of the Philippine Society of Medical Oncology.
Good evening, ladies and gentlemen. I am Dr. Juanita Lu-Lim from the Philippines, Chair for this session on lymphoma. The next lecture is entitled The Changes in Treatment Paradigm for Diffuse Large B-cell Lymphoma and Follicular Lymphoma. Our distinguished speaker is Dr. Daryl Tan Chen Lung, board member of the Chapter of Hematologists at Mount Elizabeth Novena Hospital, Singapore. He is a managing partner at the Raffles Cancer Center and the Director of Research of Raffles Hospital. He has been the clinical lead for the lymphoma and multiple myeloma services at the Singapore General Hospital and has spearheaded several clinical trials examining novel approaches in the treatment of lymphoma and multiple myeloma. He is an assistant professor at the Duke NUS Graduate Medical School and has received numerous grants from the National Medical Research Council, Singapore Health Foundation, and the Singapore Cancer Syndicate for his research. Ladies and gentlemen, let us all welcome Dr. Daryl Tan Chen Lung.
Good afternoon. Thank you very much for the kind introduction and the invitation to share with everyone on follicular lymphoma and diffuse large B-cell lymphoma. So of late, immunotherapy has radically changed the treatment landscape for many cancers. For solid tumors, it is predominantly with checkpoint blockade, but for lymphoma and leukemia, there are various forms of immunotherapeutic approaches. It started with passive immunity with rituximab in the year 2002, and now we have biotechnology, antibody drug conjugate, and the latest hype right now is probably with chimeric antigen receptor T cells. And these have made a major impact on the way we're treating lymphomas. So over the next 15 to 20 minutes, I would like to share with you how these modalities of immunotherapy have influenced the way we're treating these non-Hodgkin lymphomas. First up, I'll talk about follicular lymphoma, which is the most common indolent non-Hodgkin lymphoma. Patients typically present with advanced stage disease. The median survival is about 15 years now. And do take note that spontaneous regression happens in about 10 to 15% of these patients, and transformation to aggressive lymphoma is still the leading cause of mortality amongst patients with follicular lymphoma. Now, this is the general algorithm that you can expect to find in most textbooks and most guidelines. Let us focus on limited stage follicular lymphoma, where the traditional approach is with curative intent radiotherapy. With the advent of PET scan, ability to measure minimal residual disease, and the introduction of rituximab, I'll discuss with you on how these have influenced the conventional approach with just radiotherapy alone. This is looking at a recent publication by the International Lymphoma Radiation Oncology Group, showing that after radiotherapy for stage 1-2 follicular lymphoma, you can expect the median progression-free survival at 10 years to be about 50%, which is very good. However, if you were to dissect this by PET-based staging, you appreciate that really the stage 1s are the ones really benefiting from radiotherapy, because you can see a plateau at about the 70% mark, whereas the stage 2s, they're still experiencing a continual relapsing trend. And recently, this is data from the Australian intergroup showing that addition of adjuvant therapy like rituximab could improve upon the outcomes seen with radiotherapy alone. But the question is, who really benefits from adjuvant treatment? So now, for follicular lymphoma with stage 1 to to disease, there can actually be three scenarios. First scenario is when you don't have circulating cells, or patients have low circulating cells, and after radiotherapy, these low circulating cells could spontaneously regress. And third scenario is when you have high or abundant circulating lymphoma cells, and this is probably when you might want to consider adjuvant rituximab as a consolidation. So the Italian group has shown, although with small numbers, that amongst patients who were MRD positive, based on BCL2 rearrangement, these patients benefited from getting adjuvant rituximab. In time to come, perhaps with our ability to measure minimal residual disease, this could perhaps inform the need for adjuvant systemic treatment. But majority of patients with follicular lymphoma will present with advanced stage disease. For the longest time, it was thought that despite intensifying chemotherapy, we could not defy its natural history. But along came rituximab in the year 2002, and with rituximab, the survival curves separated very distinctly, and survival of follicular lymphoma has improved. The net effect is that survival of follicular lymphoma is approaching and getting closer to expected survival of healthy population, such that we're converting the disease from a terminal cancer to a chronic disease. Now, for patients with advanced stage disease, the first dichotomy is to distinguish if they have a low tumor burden or high tumor burden. Low tumor burden, the conventional recommendation is watchful waiting, but with the advent of rituximab, the UK group looked at its role in patients who are asymptomatic. They show that by giving rituximab, although you can improve the time to progression, but overall you do not impact the overall survival, and hence currently the recommendation for patients with asymptomatic or low tumor burden follicular lymphoma is still with watchful waiting. Now, for patients with high tumor burden, we all know from these various randomized trials that rituximab added to chemotherapy will be advantageous, but the question is, what is the optimal chemo? The Italian intergroup compared patients needing treatment. They were randomized to R-CDP, R-CHOP versus R-fludarabine mitoxantrone, and they showed that R-CHOP and RFM were superior in terms of efficacy, but when it comes to overall survival, there was no difference at 8 years, and most importantly, the toxicities associated with fludarabine was high, especially the risk of second malignancies. As patients are surviving longer and longer, now probably we ought to do no harm. So I would probably avoid fludarabine as first-line treatment for patients with follicular lymphoma. How about the role of bendamustine? This was answered by both the American BRAC study and the German STIL study. They both showed that BR is superior to R-CHOP, giving very impressive progression-free survival. So overall, BR is superior to R-CHOP when it comes to follicular lymphoma needing treatment. Now, is there a better anti-CD20 antibody? For the longest time, follicular lymphoma, rituximab has been the king of the hill, but over the years, several other compounds have been developed. And the compound that gained the most traction is obinutuzumab or Gazyva. This is by virtue of a bioengineered hinge joint that allows better ADCC and cell killing. The Galen study is a large phase 3 international randomized study comparing Gazyva chemo versus R chemo, and I'm sure everyone is familiar with data now showing that the progression-free survival is significantly superior with the use of Gazyva chemo versus rituximab chemo. So far, no apparent overall survival difference has been detected. But if you were to look at the backbone, the different chemotherapy backbones, you'll see that by adding Gazyva to chemotherapy, you'll see an advantage with regard to the PFS. And also the incidence of MRD negativity with addition of Gazyva to the chemo is comparatively superior compared to using rituximab chemo. In essence, Gazyva may overcome the shortfall of weaker chemo component. Now, how about the role of maintenance rituximab? This has been very well answered by the PRIMA study, where patients having come off treatment with our chemo were randomized between rituximab maintenance versus observation. And they could show quite clearly 10 years out that 2 years of maintenance rituximab could give you a PFS difference of 51% versus 35% when you're 10 years out. So this is, again, a standard of care for patients with follicular lymphoma. Now, a more provocative question is whether we can drop upfront chemo altogether. A study almost 20 years ago from the NCI group has shown that the gene expression signature of the infiltrating immune cells is a greater determinant of prognosis than the gene expression signature of follicular lymphoma cells themselves. So in essence, what's happening is that in the presence of follicular lymphoma, the immune cells become defective and they are not able to form effective immune synapses required for killing of the follicular lymphoma cell. One drug that can repair this defect is lenalidomide, an immunomodulatory agent. So this was evaluated in the relevant study. So for the first time, you have this major randomized trial comparing R-squared regimen, rituximab plus lenalidomide. I would say R-squared is probably a match made in heaven because rituximab attacks the cancer cell for immune cell killing that is beefed up by lenalidomide. And this is compared against rituximab plus investigators' choice of chemotherapy. The results are now published in the New England Journal of Medicine. Although you don't see any discernible difference in the PFS and the overall survival, but this is, again, the first time you're comparing our chemo versus a biologic couplet without chemo, which is a chemo-free approach. But although there's no difference here, I would say that the R-squared regimen is probably a winner to me because when you look at toxicities, now you're removing the toxicities you see with chemotherapy. And certainly this is a regimen that I could consider for patients who are not eligible to receive conventional chemotherapy. Now, how do we take in all these frontline data for follicular lymphoma, which I've alluded earlier on? Now, if you look at the first studies, by adding rituximab to chemo, you get an advantage in PFS. R-benda is superior to R-CHOP, and now if you were to add the maintenance, you will extend the PFS a little bit further. Clinical study has confirmed the advantage of maintenance rituximab, and Lu-Lim study has shown that by upgrading your anti-CD20 antibody, you now get a higher or better PFS compared to R chemo, and the relevant studies showed comparable PFS. But overall, what is common across these studies is that there is still no overall survival difference shown. If I were to bring you back to the Stanford data showing improvement in overall survival over the years for follicular lymphoma, you will appreciate that the improvement is attributed to the way we're able to salvage these patients when they relapse and not really based on how we're treating them in the frontline setting. Right, so it is important that we must have good drugs in our therapeutic armamentarium when these patients with follicular lymphoma relapse. This is how we can really prolong their overall survival. However, there is a caveat here. If you look across all the different trials in the frontline setting, you always appreciate that 20% of these patients may relapse within 2 years of treatment. And this is not due to histologic transformation, but this is due to progression of follicular lymphoma, the indolent component itself. And if you look at the survival of these patients who progress early, these patients are known as POD24 or early progressors. You see that the median survivor is actually at 5 years, which is very dismal compared to what I've mentioned about the median survival of 15 years or more for patients with follicular lymphoma. And this is, in essence, we're still dealing with a subset of patients with follicular lymphoma where they're still having a terminal cancer and not just a chronic disease. So the unmet need is really the ability to identify patients who could progress early. One prognostication system that is gaining a bit of traction is M7 FLIPI that looks at FLIPI plus some biological risk factors based on gene expression profiling. And this system is able to identify more patients who may progress earlier compared to the rest of the patients. And what do we do when these patients relapse? So if we're looking at patients who are early progressors, one strategy actually is autologous stem cell transplant. The German group, as well as database from the American CIBMTR data set, has shown that if you do an autograft for patients who are early progressors, they may enjoy a longer survivor. And this is probably what I would do for patients who are relapsing early and transplant eligible. Otherwise, another effective salvage regimen is the combination of Gazyva or obinutuzumab with bendamustine. This is shown in the Gandolin study, where patients who were rituximab refractory were randomized between GB versus bendamustine, and they could show a progression-free survivor advantage with the use of Gazyva with bendamustine, and this actually led to an overall survival advantage for these patients who were rituximab refractory. Certainly a very effective salvage regimen for our patients with follicular lymphoma. So to conclude my segment on follicular lymphoma, survival of follicular lymphoma has improved significantly. Excellent prognosis after radiotherapy with PET stage 1 disease. BR is superior to R-CHOP, and immunomodulation allows the possibility of a chemo-free strategy. There is still an unmet need for novel strategies for patients who may progress early. Now, moving on to aggressive diffuse large B-cell lymphoma. So what has changed over the years? R-CHOP still remains the gold standard for treating patients, whether patients are older or younger, based on the French GILA study and German study. But if you look, if you look at population perspective, you appreciate that despite R-CHOP, 30% of patients will still eventually fail. And previously, the PALMA study has informed that standard of care for patients who have failed R-CHOP is with autologous transplant, where you can still salvage 50% of these patients. But in the rituximab era, the CORAL study has actually informed that salvaging patients who have failed R-CHOP, especially if they fail within the first year of coming off R-CHOP chemotherapy, the outcome is dismal. 3 years PFS is barely 21%. Patients are really poorly salvaged after failing R-CHOP. So if we were to start hypothetically with 300 patients with DLBCL, eventually we could actually expect 100 patients to fail R-CHOP, and now fewer patients will be chemosensitive after they relapse from R-CHOP. Fewer patients will receive autografting, and autografting results will certainly deteriorate. However, do we drop autologous transplant now in the rituximab era? Data from the EPMT registry, however, has suggested that if you are able to carefully select patients for autologous transplant, this would be patients relapsing beyond 1 year of R-CHOP treatment. They could still gain a meaningful progression-free survival advantage with autografting. There are some strategies to improve autologous stem cell transplant results, or allowing more patients to get autografted. So one way is to improve the salvage chemo. We can improve the conditioning before transplant, and we can try to prevent post-transplant relapse. So several strategies, as shown here, have failed to identify a regimen that is better than RIs or RDHAB. How about improving the conditioning? So there was an attempt led by Julie Vos adding AOS131 tocilizumab, which is a radioimmunotherapy to beam conditioning. However, this was a negative study. It resulted in more toxicities. The second component of the CORAL study actually looked at maintenance rituximab after stem cell transplant, and again, this is a negative study. Currently, there is an ongoing study looking at adding ibrutinib, a BTK inhibitor, for patients with ABC type DLBCL post-transplant. We're still awaiting results for this particular study. So overall, perhaps rather than focusing on patients who have failed failed R-CHOP for DLBCL, perhaps a better strategy is to really focus on these 100 patients who may fail DLBCL. The first card is really to be able to identify who these patients are, who will fail R-CHOP eventually. So one way is to look at the biological risk of the disease, and another is to look at the clinical risk of the disease. So the WHO classification, the latest classification in 2016, has actually highlighted who these poor biological performers will be. So these are patients with double or triple hit lymphoma. You know that the survival outcomes will be dismal. Then there are patients with activated B-cell type DLBCL. The outcomes generally poorer compared to those with GCB type DLBCL. The double expressors will be somewhere in between. Perhaps we could focus on these bad players and see if we can improve the outcomes of DLBCL with R-CHOP. And for clinical risk, the IPI is still relevant in the rituximab era. This is looking at revised IPI. Two groups have shown that it is still predictive of survival outcomes. So how do we improve upon R-CHOP? One way is to increase dose density. Unfortunately, two studies from UK and from France have shown that R-CHOP 14 is not superior to R-CHOP 21. How about increasing the dose density or dose intensity? This is by way of doing upfront transplant for patients with high clinical risk or high IPI. The American study has shown, which is now published in NEJM, has shown that in the randomized fashion in the rituximab era, despite autologous transplantation for patients with high risk IPI, although there was a PFS advantage overall, this did not lead to an overall survival advantage, and hence this is still considered a negative study. Easier way instead of stem cell transplant is to do dose-adjusted EPOCH-R, which is an infusional regimen. Unfortunately, the recent CAA-LGP or Alliance study, which randomized patients between DA-EPOCH versus R-CHOP, has shown no significant difference with regard to EFS and overall. Because if you look at retrospective series to the left from MD Anderson and to the right, the US intergroup analysis, it shows that amongst patients with double hit lymphoma, they tend to do better if they received EPOCH compared to R-CHOP. So another series has also shown that amongst patients who were able to attain a CR with the use of EPOCH, there was no advantage in doing an autologous stem cell transplant. So based on these retrospective analysis, I would probably still recommend EPOCH-R for patients with double or triple hit diffuse large B-cell lymphoma. Now, how about adding an agent, a novel agent to R-CHOP? So this is predicated on our improved understanding of the biology of diffuse large B-cell lymphoma, and in particular patients with activated B-cell type DLBCL, because we know that there's constitutive upregulation of B-cell receptor signaling, and by targeting these downstream targets, perhaps we could improve the outcomes of these patients with ABC type DLBCL. So these are the various agents that were evaluated. Unfortunately, just to summarize, most of these agents did not actually make the mark, and the latest victim was bortezomib, and several studies looking at adding bortezomib to R-CHOP did not improve outcomes of patients with ABC type DLBCL. The later generation of trials look at adding ibrutinib to R-CHOP. This is the Phoenix study. Unfortunately, it was a negative study as well. And also looking at lenalidomide added to R-CHOP. There are two studies here is sending off mixed signals. The robust study focused on patients with ABC type DLBCL is a negative study, whereas the ECOG study that added lenalidomide to all comers showed an improved PFS. So this area, it is still controversial as to whether lenalidomide is improving the outcomes of R-CHOP. How about tweaking the immunotherapy component of R-CHOP? Earlier on, you've heard about obinutuzumab, which is a next generation anti-CD20 antibody. So this was evaluated in the Goya study where patients were randomized between G-CHOP versus R-CHOP. Unlike the Lu-Lim study, there was no difference in survival outcomes at all. So currently, we're looking at a new compound called polatuzumab vedotin. So this compound is the antibody drug conjugate. So the immunotherapy component of this compound targets CD79B on which is part of the B cell receptor complex. And once it attaches to CD79B, the compound is internalized and it unleashes NMAE, which is an anti-tubulotoxin, and this results in cell apoptosis. Now, actually, polatuzumab vedotin has been evaluated in the relapse setting for patients who were transplant ineligible, and now it is approved in America and in Singapore for patients who are transplant ineligible. This combination is polatuzumab vedotin plus BR, and it's able to record progression-free as well as overall survival advantage. Now, coming back to the frontline setting, right now, many of us are very excited about over this regimen called this study is called POLARIX study, where we're comparing R-CHOP versus polatuzumab vedotin plus rituximab plus CHP. It remains to be seen whether this will be a better upfront regimen compared to R-CHOP. Now, so I've highlighted various strategies to improve upon R-CHOP, but I guess it is probably easier said than done. So far, nothing is, no regimen is convincing. So this is still my approach in the year 2020. For most patients with diffuse large B-cell lymphoma, R-CHOP remains standard of care, with the exception of patients with double-hit lymphoma. I will start with R-CHOP, I'll start with dose-adjusted EPOC. But for those who are not, who cannot tolerate EPOC and receive R-CHOP, eventually, if they attain the remission, then I could consider upfront transplant for patients who have a double-hit DLBCL. Now, amongst patients with primary progressive DLBCL or refractory DLBCL, they probably have the worst outcomes. From a study, Scholar study, it's been shown that patients with refractory DLBCL, the median overall survival is just merely 6 months. So this is a focus on many novel therapeutic approaches, of which CAR T cell seems to perhaps fit the bill in this setting. So CAR T cells works by bioengineering autologous T cells so that this gets infused back to the patient to take out the lymphoma cells based on CD19 targeting. So right now there are 3 commercial products, exacaptogene, tisagenlecleucel, and JCAR compound. Tisagenlecleucel has actually been approved. It's a Novartis compound. Overall, you can expect like 50 to 80% response rates, and half of these patients attain a CR. CR is the prerequisite to curing the patient from diffuse large B-cell lymphoma, and we're still eagerly awaiting long-term data with the use of CAR T in diffuse large B-cell lymphoma. Now, coming back to this model again, well, with the advent of CAR T, perhaps we could salvage some of these patients that cannot be, who are transplant ineligible, as well as patients who have failed autologous transplant. In fact, there's currently a trial called the Berlin study that's randomizing patients between autologous transplant versus CAR T when they first relapse from R-CHOP-based regimens. And overall, with the introduction of CAR T, perhaps we could cure more patients with diffuse large B-cell lymphoma. To summarize, for diffuse large B-cell lymphoma, fewer patients will show chemosensitive disease after R-CHOP, and fewer will benefit from autologous transplant. Predictors of poor response to chemo or salvage transplant include rituximab exposure, relapse within 12 years of treatment, PET positivity after salvage, or MYC expression. CAR T therapy may bridge the gap for patients who are chemo refractory. And with that, I thank you for your attention, and I'm happy to take any questions.
Yes. Hello.
Hi, how are you?
Thank you. Yes, thank you, Dr. Dalitan, for your excellent lecture. You have packed so many information in very short time. And then we have some questions for you from the participants. Okay. One question here is, do we have special recommendations for elderly patients, or the recommendation of treatment are the same?
Yeah, certainly the recommendations would be different for elderly patients. First of all, we have to define if still going for cure for the elderly, or we're just going for palliative treatment. because the treatments recommendations can be very different. For very frail patients, probably they will not be candidates for R-CHOP. So these are the ones that I may palliate with a little bit of rituximab steroids or even bendamustine rituximab, knowing that this will not be curative and it's just palliation and to buy time. But for patients, elderly patients who are still potentially going for curative intent, then of course the first stop is to make sure that the heart can take anthracycline. The 2D echo or MUGA scan would be important to check the heart function. And if they can tolerate anthracycline, I will still go for R-CHOP, but this time around, not the conventional R-CHOP, but mini R-CHOP. So there's a publication by the French group looking at the mini R-CHOP where all the doses of the components of CHOP have been reduced. For instance, cyclophosphamide is dosed at 400. It's almost half the dose of the 750 per meter squared. Vincristine at 1 milligram, anthracycline or adriamycin is at 25 milligrams. So our mini R-CHOP is quite effective for some of the elderly patients and even curative for some of these elderly patients as well. So it's way more tolerable. And also there is a recommendation for pre-phase where you could do prednisolone for about a week before implementing or starting the R-CHOP regimen. This, in a way, will allow the patient to ease into the full dose chemotherapy. Certainly, the treatment approach for elderly will be different. And of course, elderly patients, most of them, if they are beyond 75 years of age, they probably will not be candidates for EPOC regimen.
Okay, thank you. And someone asked, what is really the recommended number of cycles for R-CHOP for the diffuse large B-cell lymphoma? Is it 6 cycles or 8 cycles?
Right. The question was actually answered by the German Recover 60 trial. So in that study, they compared 6 cycles of R-CHOP versus 8 cycles. So overall, there was no significant difference between 8 and 6. Of course, but in the ESMO guidelines, you will still see recommendations of 6 to 8 cycles. But generally, we'll take 6 cycles as the recommended number of cycles for patients because you don't add any further advantage by adding 2 more cycles. Nowadays with PET scan, it is quite clear and quite definitive. If I still do not get my PET CR by 6 cycles, then probably I would want to investigate further and probably not give 2 more cycles. So overall, the recommendation is still with 6 cycles, but in the guidelines, ESMO guidelines, some may recommend like 2 more doses of rituximab, which is fairly which is certainly reasonable. 2 more doses of rituximab, but I probably wouldn't give 2 more cycles of CHOP if the patient is already in complete remission.
Can you elaborate more on the how to measure the minimal residual disease to determine who would benefit from the adjuvant treatment after RT in early follicular lymphoma? When to do this and what is the best specimen to use? Yes. And what specific test to order?
So I actually wouldn't advocate this as a standard of care as yet. So it is still not prime time for us to use this to inform treatment decisions because after all, this is based on very preliminary studies and the number of participants in the trials were actually very small. But that example was just to highlight to everyone how the direction of hematology is moving. We are now beginning to measure more and more minute amount of diseases whereby MRD is certainly a very significant element for us to measure. But certainly it has not been validated in bigger trials. So I actually wouldn't recommend you doing that for early stage follicular lymphoma. But if you have the resources and if your ability to measure that is available. Usually what I do is PCR for BCL2 rearrangement from the peripheral blood. That is how I would check. This is what the Italian group did as well. But otherwise, I must qualify that this is still not ready for prime time.
Okay, thank you again, Dr. Daryl Tan. Our time is up. I'm sorry. Okay, thank you again for your excellent lecture, and I would like to thank all the participants for joining this session. Thank you.
Thank you very much.